This is Dr. Ben White with the Rational Wellness Podcast, bringing you the cutting edge information on health and nutrition from the latest scientific research and by interviewing the top experts in the field. Please subscribe to the Rational Wellness Podcast on iTunes and YouTube, and sign up for my free ebook on my website by going to drwhites.com. Let's get started on your road to better health.
Rational Wellness Podcast. Thank you so much for joining us again today. For those of you who enjoy listening to the Rational Wellness Podcast, please go to Apple Podcasts and give us a ratings and review. That would be very much appreciated. That way more people can find out about the Rational Wellness Podcast. Also, you can go to YouTube and there's a video version. And if you go to my website, drwhites.com, you can find detailed show notes and a complete transcript. I'm very excited today that our topic is, we'll be talking about how to prevent and reverse cancer with Dr. Nasha Winter. Dr. Winter is a licensed naturopathic doctor and a fellow of the American Board of Naturopathic Oncology. She's also a cancer survivor herself. Dr. Winters is a sought-after speaker and an authority on integrative cancer care. And she's currently involved in research on using mistletoe extract, hyperthermia, cannabis, the ketogenic diet, and IV vitamin C to treat cancer. Dr. Nasha is a co-author of the best-selling book, The Metabolic Approach to Cancer, which is an amazing book. And she's finishing a second book on therapeutic diets for cancer. Dr. Nasha is on a mission to educate and empower the nearly 50% of the population expected to have cancer in their lifetime, and prevention is the only cure. Dr. Winter, thank you for joining me today.
Thank you so much for having me here. It's a lot of fun already. Before you started recording, we were already in a good space.
Good. Can you start by telling us about your own personal cancer journey?
Sure. I think that most of us who come to the field of medicine, especially something more of like an integrative or functional medicine, sort of like you and I, we didn't just say, hey, I woke up one day and decided this is the career for me. It's usually some story of our own personal experience or someone we're very close to that brings us to this. And I'm no different than that. And, for me, I just was sort of started off in the world with a lot of healthcare issues, struggled with that all my childhood and into my teenage years, to the point where my symptoms, my digestive symptoms, my hormonal symptoms they became just commonplace for me. Like I didn't even recognize that I was sick. Right. And so, it was just like put on another medication or just ignore it or just cope with it. So by the time I started having some really intense symptoms that I was someone who had I still do have a very high pain threshold and avoid medications at all costs and different things. But there was a time in my freshman year in college where I was like debilitated with pain that would literally I would pass out. I would throw up from the pain in my abdomen, in my pelvis. I would show up in the ER on several occasions over about a 9-month period of time. And each time they sort of patted me on the head and said, you're histrionic. It's maybe your endometriosis still flaring. Maybe you've got Crohn's or IBS. And it just sort of like, here's another pharmaceutical and send me out the door. And it just happened over and over until finally I landed in the ER, tachycardic. The lab showed my organs, my kidney and liver were in complete end stage.
Wow.
I had a hugely depleted abdomen. I know. And that's when they realized, oh God, this woman has liters and liters of fluid built up on her gut, in her abdomen. And when you see that sign now as a doctor looking back, that is ominous in all situations. It's always cancer. I can't think of a single time when it wouldn't be. And so that's when they finally did proper workup and had to deliver the bad news that they'd found a grapefruit-sized lesion on my right ovary, lesions on my liver, scattered lesions all throughout my pelvis, and basically said you're in end-stage organ failure with further testing of the ascites fluid, a biopsy, and multiple lab tests and diagnostic imaging, came to the conclusion I was in-stage ovarian cancer. And this is 19 going into my 20th year on this planet. And so that was the official diagnosis came October 21st, 1991. And we're coming on 28 years out from that. And
awesome.
Right, I know, woo! And the crazy part is I was so sick, I was so far gone that they said at that point, even a single dose of chemotherapy would kill me. Their recommendation was hospice, palliative care, and they would give me a second, give me into an oncologist for a second opinion, but they knew that, I had 3 months with no treatment at best, and likely a treatment. If I started to try to do chemo, it would probably kill me outright because my organs were shut down. So that made sense. And really what they could offer me was palliative support with draining the fluid on my abdomen and basically keeping me comfortable. So I think, again, in my world, when you're given no choice, many other choices open up. And that sent me on what has become a very long and powerful journey for me, for learning for myself, but also for thousands and thousands and thousands of other patients and colleagues that I'm now working with, mentoring and learning from as well. And it's, again, we find our purpose in the most odd ways, right?
What would you think were the most impactful therapeutics that helped you?
Well, in retrospect now, there are two main ones. Okay. The first one was I had so much valuable real estate taken up by the fluid in my abdomen that I could not eat. I could not keep anything down. And so I fasted, not on purpose, not by thoughtful desire or devised on medical scientific wisdom. It was out of necessity that I probably fasted for 30 to 60 days in that first bit of time.
Wow.
It was weeks. I meant what little bits I could take in were very small amounts and water only. What we now know in retrospect, looking back, in fact, another study just came out this week of the use of intermittent fasting with cancer treatment and enhancing of all conventional therapies as well as other therapies. That was probably one of the most profound things I could have done for myself.
Wow.
And that was not thought out. Right? It just happened. Kind of like animals in nature, we observe that kind of do what they need to do to take care of themselves. I was an animal in nature doing that. The second thing, which is often more challenging to discuss, is understanding the psychological reasons for why these things happened. In fact, I was a biology chemistry major pre-med in medical school, and this event woke me up so much that it switched me to a psychology biology major and basically a self-created major in psychoneuroimmunology. This is when work of Candace Pert, Deepak Chopra's book is actually one of the first books I ever read in this field, Bruce Lipton, all of these things started to help me understand where I was coming from. And ironically, I worked as a detox counselor at that time, worked in the realm of addictions, was raised in a pretty traumatic environment. If you and your listeners are at all familiar with the adverse childhood events, the ACE questionnaire, the ACE score, basically the studies or research shows that about 64% of our population has at least one significant adverse childhood event. That's really significant. And that alone can increase their risk of conventional diagnoses of chronic illness in their adulthood. And basically, if you have 3 or more yeses to that 10 questionnaire, you have like a 400% likelihood of having a chronic illness in your adulthood. And just to give context, I was a 10 out of 10. So it was no wonder, and actually, but of course, that I had that diagnosis. So something in me understood that at a very young age when this wasn't a common discussion out there in the world. So one of my other big, what did I do for myself processes was I did a family fast for almost 2 years. And so not only did I have a food fast out of necessity, I also had a family fast. I went into kind of a lockdown of deep support for myself because a couple things I knew from the get-go is a lot of the people in my circle would have made this much more about them than me, and I wasn't ready to deal with that. I didn't have the financial support. I was uninsured. I didn't have any, I was putting myself through college, the first person in my family to go to college. There were so many factors here that I physically moved away from the trauma and the place that created a lot of this for me. And I wasn't going to go back, was not about to go back into that. And so it just sort of worked out that it was a perfect time for me to sort of cut off all those ties and start my own new tribe of resources and support. So fasting in a variety of ways became very instrumental in my health and well-being.
Did you seek integrative care at that time?
It's interesting because what I started learning about at that time was the pain was probably my largest physical symptom, and the nausea and digestive upset. And I found an acupuncturist, and she was an RN in our community. She's since retired, who I was seeing her 2 to 3 times a week for acupuncture. And she was doing stuff for my digestive tract and for my pain management, and then side effects, stress management, and other things. And it became a really powerful tool of support for me. And then I started working in a health food store, and I worked in the vitamin aisle, the supplement section. I started learning everything I could about herbs and nutrients and supplements. And we had a local herbalist in our community. I started taking classes with her, started working with Rolfer. I just started exposing myself to concepts and modalities because I wasn't given any choices in the Western medical model. So I thought, well, I want to be.
You got no Western care, no chemo, no radiation.
Outside of labs, some imaging, ongoing imaging, which then later, because at that time the imaging we used was MRIs. So I blew out my kidneys thanks to that. I still have a lot of kidney issues because of gadolinium poisoning. So that back then, that's a tough one. I've been working on trying to get gadolinium out of my system for 28 years, and it's holding on for dear life. So at least I have my kidneys fortified enough that they are functioning okay. But it takes it's a lot. So those are exactly it. When I actually didn't expect to survive. Number one, let me just be that. I was not on a mission to treat this. I was more on a mission to understand this. And that has been what has really informed the way I approach today, is I believe that empowerment, knowledge is very good medicine. And so to understand the why I got to where I was just as important, if not more important, than what I was going to do about it. So today I have a lot of colleagues out there doing great, I can do these IVs and I can do this treatment. And I spent $70,000 over here in this country doing all these therapies and yet still are sick. That's missing one of the critical pieces of this journey is, well, why did you get sick in the first place? What about your construct allowed for this to take root and flourish? What can we do? We can't heal from the same soil in which we got sick. So what needs to happen now? Understanding where we came from is really powerful to help us understand where we need to go.
Interesting. Yeah, that's really fascinating. I just recently interviewed in last week's podcast was with Dr. Alan Goldhammer, and he has a long-term fasting program. He puts patients on a water-only fast for up to 40 days, and he has some documented cancer cases.
Mm-hmm. Yeah. And it's interesting because I know that he has certain ideologies around the type of foods you should eat when you are eating again.
A little bit different than the type of foods.
Definitely. Yeah, I was laughing. I'm like, oh, good. You have me right after. So we'll be like the yin and yang of this.
We went to battle pretty good.
But it's beautiful because what I really want people to understand is there are multiple ways to reset your metabolic system. There are a variety of ways to restore health. There is no one way. And so because I'm such an avid tester, if someone's like, hey, I'm doing vegan raw food, great. Well, let's see if that's working for you. Let's look at your labs. Let's look at your genetics. Let's look at your constitution. Let's see if that's working. Just the same way people are like, I'm a hardcore carnivore. Okay, well, let's take a look and see how that's working for you. And there are so many surprises under the hood. You can't look at someone and say, oh, you're going to be great on this, right? That's
Absolutely.
What you love. When people start to get dogmatic and into, frankly, pissing contests on what's the best way to go about it, I'm like, just show me the data. I'm kind of straightforward.
Absolutely. Let's test you and let's see how you're doing. How are your lipids? How are your inflammatory markers? Yeah.
Nailed it. Yep. Yeah.
So conventional oncology focuses on figuring out the diagnosis. Do you have cancer? What kind? What stage is it in? And what the proper treatment, whether it be surgery, chemo, radiation. But you focus on the terrain, the situation in the body in which the cancer is growing. Can you explain why we should focus on the terrain?
Sure. You said it, you really introduced the concept well, is that Western medicine, standard of care oncology, is expert at the tumor and the tumor cell. They are spending billions of dollars every year understanding all of the components of the tumor cell, all the different individual pathways and the different targets on those cells. And yet we've barely moved the needle on the dial of really changing survival outcomes and the diagnoses of this to begin with. So just to give an example, stats for your listeners, 1 in 2 men, 1 in 2.4 women expected to have cancer in their lifetime in the United States. And World Health Organization statistics show that cancer worldwide is expected to double by 2030. So that does not show me that we're making a lot of headway with the way we approach cancer from the get-go. All right. Not to say that those therapies aren't powerful, but they need to be brought into context with the whole organism. So my expertise is I don't treat cancer. I don't treat cancer types. I don't treat tumors. I treat the terrain wrapped around those tumors and the tumor cells. I want to understand the why. And it's interesting because that might sound a little hooey or hokey to a lot of your listeners, but here's what's interesting. There was a woman by the name of Mina, M-I-N-A, Bissell, like the vacuum, that has been in oncology research for going 35, 40 years at this point, and she is expert in extracellular matrix, tumor microenvironments, basically being what soil is that tumor living within. And she has been showing and has some beautiful TED Talks and other YouTubes on her understanding as a cancer researcher to show that we have been putting all of our attention in the wrong place. And so what is also very interesting is what we've learned in the last 15 years or so is that even an individual tumor has multiple tumor types. So it's this concept of heterogeneity, so genicity. So basically it means you might get one biopsy that shows this one target, and yet if you kind of took the whole tumor out and you dissected it down to all these little infinite particles, you'd probably find 5 to 20 different tumor types all on one. And so the concept of how we treat with these targeted therapies or hormone disruptive therapies or chemotherapy or surgery or radiation is, number one, it only impacts the target they're shooting for. And you're only getting part of the information. So you might get lucky, right? But 70% of the time, if you have success the first time around, 70% of the time you're going to have a recurrence. And you're not going to get so lucky because it comes back a bit louder and a little bit more obnoxious and a little bit more resistant. All right. The other thing is that there are multiple patterns and processes happening, even within each of those targets. So when we start to play what we call the whack-a-mole game, you push one down, you're going to pop up another response. So a good example is like angiogenesis inhibitors, like VEGF inhibitors, like Avastin. Okay, you will watch in these labs, because I watch their labs and I watch their blood biopsies, like through companies like Guardant 360.
Right.
We'll look at VEGF, and if it's normal or elevated when they start Avastin, after 3 to 6 months, you'll start to see that VEGF go up and up, even on the drug. Because that drug is now starting to create new pathways and new resistance. And that's what happens in all of our standard of care. So let them come in and do the targets and do the treatments that are affecting those fast proliferating cells, because chemo, radiation, surgery only address fast proliferating cancer cells. They also, at the same time, make dormant cancer stem cells come alive, mutate further, and become more or become less responsive to any of those standard of care treatments. So it's in the extracellular matrix. I call it the terrain. Some people call it the tumor microenvironment, that if we put attention there, we can help overcome some of that treatment resistance. We can actually enhance outcomes of standard of care therapies, and we can certainly make the organism feel a hell of a lot better while they're going through the process. That's where I put my focus. That's where my expertise lies.
This is really an excellent discussion, but I'd like to take just a minute to tell you about our sponsor for this episode. For this episode of the Rational Wellness Podcast, we partnered with Hedry, a collaborator in university studies on CBD, with their own 2 unique formulas available to the public, Good Morning and Snooze. Designed for around-the-clock wellness, they feature CBD infused with specific terpene combinations to help you manage negative thoughts and experience clarity throughout the day and night. Visit Hedry, spelt HEADERY.com, and use the coupon RATIONAL for 20% off. And now back to our discussion. I also think it comes to the difference between individual molecular pathway with one drug that hits one pathway versus what every brand is called systems biology.
Yes.
And I was in a seminar that Nalini Chilkov gave a few years ago.
My girl.
Spoke at our functional medicine meeting a couple of months ago. And she put up this chart, which she got from, one of the big pharma companies, and they're working on this pathway, and they have this one drug that might hit this pathway. And then they had all these genes, and this might hit this gene, this might hit that gene. And then she put up a chart of curcumin, and it hit like 40 different pathways. None of them is strong as these targeted drugs, but the amazing, power of diet and lifestyle to affect so many different pathways.
Yes. And that's just it, is people like Dr. Mina Bissell showing that, but even Argaval, Bharat Argaval, who was at MD Anderson for years, he was the famous curcumin researcher, but he also has some pretty great quotes that says, we're given the opportunity to do chemotherapy 3 times a day, which is what sits at the end of our fork, right? And it's like the foods you choose can either be pro-cancer or anti-cancer. And not like they are cause or effect. It's not that, but they enhance or change the terrain in a way that increases inflammation or increases stress in the body or depletes the immune system or strengthens those patterns. That's how we think about things, the way we can use integrative therapies as ways to enhance the overall system's response to a standard of care approach.
So in your book, you talk about the 10 aspects of the terrain, and there's so much great detail in this book that we could talk about it for hours. Yeah. And I encourage everybody to get this book and read it twice. But maybe we can just touch on, 1 or 2 things from each of these chapters.
Perfect.
To begin with, though, when you assess the terrain, you have a questionnaire in your book, but I wonder, is there like an ideal cancer biomarkers lab panel or?
Great question. My patients have coined the term the trifecta. And this is a combination of testing I've done for over 20 years in myself and in my patient population that gave me a personal indicator, like an indicator light to say cancer's in the driver's seat or the terrain is in the driver's seat. So to give an example really quickly, I've had many patients who've gone through standard of care treatment who by all accounts on their tumor markers and their scans are no evidence of disease, NED, right? And they're super happy. And then I look under the hood and I'm quivering in my boots, okay? And then I've seen the other be true, where I've had patients, myself included, who have things on scans and still may have elevated tumor markers, but the terrain looks gorgeous, which basically means that they're in the driver's seat and the cancer just maybe in the passenger seat, and it's not causing problems. It's not growing. It's not going away, but it's stable. Okay. The key of us changing the cancer conversation is around stability and maintenance and treating this like a chronic illness, like anything else. And great, if we accidentally get to a no evidence of disease, that's a great side effect. That is not the end all goal in a terrain-centric approach. So that being said, there are what I call my monthly labs. So when someone initially had a consult with me, or now I consult with doctors on behalf of their patients to teach them how to do this, I look at 5 main tests to begin with. Good old simple CBC, that's your complete blood count. That's looking, and I want it with the differential, and that's looking at your white blood cells, your red blood cells, hemoglobin, hematocrit, platelets, your RDW, your percentages of monocytes, eosinophils, and basophils, and your percentages of neutrophils and lymphocytes. And that little out-of-pocket $12 test, then that information can be make or break on somebody's prognosis just in that one test. So an example is if somebody has what's called a poor NLR, a poor neutrophil to lymphocyte ratio. You can simply go Google that right now in PubMed, and you will see hundreds of papers that come up saying that a poor neutrophil to lymphocyte, meaning more than 2 neutrophils for every 1 lymphocyte, is poor prognosis and all-out mortality across the board of all the populations. We should be screening, just taking a look at that in every one of our patients. So for instance, if you have, say, 65 neutrophils and 28 lymphocytes, you're in trouble, whether you have cancer or not. If you have 55 neutrophils and 32 lymphocytes, you're in a really beautiful zone. All right, so these are simple things we can test on that. The other thing I look at is a metabolic panel, which is going to have your glucose, it's going to have your liver enzymes, it's going to have your electrolytes. Those just show me like how, and your kidney function. That's like how are the organs holding up amongst this battle, right? And not too long ago, if you recall, probably 15, 20 years ago, when we ran a chem panel, it used to be a chem 20, okay? That used to include things like magnesium, sedimentation rate, lactase dehydrogenase, GGT, which is a particular liver enzyme, way more specific and sensitive than an AST or ALT. Today, you only get a Chem 14 at best. And so we usually have to then add those other two key players, the sed rate and the LDH into the mix. But that chem panel can show me a lot of what's going on, mostly metabolically what's going on. So if we start to see elevated ALK phos, we know there could be things with the liver, the kidney, or the bones. If we see elevated liver enzymes, that could be things like liver mets, that could be liver just overwhelm of whatever medication it's on. If we see chronically low white blood cells, that's usually indicative of chronic heavy metal or chronic confection issues. If we see a low hemoglobin, that can give us false readings on our hemoglobin A1C levels. So it might look like someone's doing great metabolically on their blood sugars, but their hemoglobin's so low that it's giving you an erroneously low level. Or we might see low hematocrit, which is also prognostic. People with low hematocrits also have poorer prognosis, and mortality rates are higher. So these are some simple things. Both these tests together are like $20, $25. The trifecta I alluded to already is the sedimentation rate, also known as the ESR, or the LDH, lactase dehydrogenase, sometimes on your test as the LD. And the third one is the CRP, the C-reactive protein. That's the trifecta. Now, again, if you went into PubMed and you looked at any of those individually, like what does an LDH mean? What does any of those by themselves are good markers for cancer and chronic inflammatory chronic illness processes. But if you have all three of those tested regularly, I have my patients retest those labs until their trifecta is perfecta. And by perfect, I want them to be in my functional optimal ranges. So for instance, a C-reactive protein, some are high sensitivity, which might have a range of up to 0.3, and some are just regulars, which might have a range of up to 3. We ideally want that under 1 or 0.1 at its highest. Anything above that, that's why you want to get a quantitative, because if it just says below 3 or below 0.3, that means nothing. I need the exact number. Same thing with the sed rates. Sed rates should always be below 10. And lactase dehydrogenase, or LDs, should be, depending if it's a Quest or a LabCorp, should be under 175 or under 450. One of them goes up to around 600. The other one goes up to like 220. You want them well within the limitations. When I'm looking at somebody's labs and one of those trifectas are out, that usually points to, hey, I just broke a leg, or I just got over an illness, or I just had an autoimmune flare. So for instance, sed rate shows how quickly do blood cells fall out of solution. If it takes a while, if that number is higher because it takes longer for those cells, that's thick, sticky blood, inflammation, high fibrinogen, and those little scaffoldings that allow cancer cells to move about the building, right? We want that low. We want really nice, thin moving blood. If LDH is high, that could be a multitude of things. It's an average of 5 different enzymes throughout the body that could be pointing to lung health, red blood cell health, liver health, kidney health, even tumor health, like to what's going on. My husband, who's a biochemist, will say if the LDH is on, basically if it's elevated, then the mitochondria are off. That's a really good rule of thumb. And it's probably the most profound marker we have for all illnesses, especially in the cancer world. And in fact, if you have lymphoma or melanoma or multiple myeloma, LDH should be the standard cancer marker that's being run every month for you. And I rarely, if ever, see that happening in the oncology world, which is just absolutely malpractice in my opinion, because it's a really good way to see. If you start to see an LDH go up in your cancer patients, you know cancer's on the move again. And then C-reactive protein we already talked about. So those three, along with the CBC and CMP, give me a lovely base camp of the terrain for about $100. And we'll retest those every month until they stabilize. Okay. Now, yeah, and that's a starting point. Now, depending on the person's history, tumor type, age, what types of therapies they're taking, I may very well add in a lot of other tests to this. But like typically, let's use breast cancer as an example. I want the markers. A lot of women don't even ever get their breast markers done. I want CEA, CA2729, and CA15-3 as your baseline. But the 3 main drivers of most breast cancers is a low vitamin D3. So anything below 50 is a problem. I want it more at a therapeutic level at 80 to 100 if they're dealing with chronic illness. An insulin above 3, is a problem. An insulin growth factor well above 100 is a problem. And a hemoglobin A1C above 5 is a problem, pretty much in all cancer types, but for sure in the breast world. And then a body fat index, not a BMI. BMIs are BS, but a body fat index above 25%. These are key metabolic drivers of things like breast cancer, a lot of colorectal cancers, pancreatic, brain tumors, et cetera. So these are some other parameters that we can really test and assess and address in a profound way to change the terrain, to change the soil, so that whatever treatments you're doing for the tumor has a better chance of taking hold.
Interesting. What do you do if you have an elevated IGF-1?
Well, one of the best and free things, fasting. Yes. Yep. And so I love that just when I see those moments happen where it can be something fasting. The high intensity interval training can do the same. Proper sleep. So know that 2 nights of bad sleep can throw your insulin growth factor off the charts. So if sleep is an ongoing issue for you, make sure you're addressing that. Stress will also kick up. So cortisol will kick up insulin growth factor, and so will estrogen and androgen dominance. So if women or men are taking exogenous hormones, even for optimization, their insulin growth factors are going to be high. And so that's not good if you're dealing with a cancering process, right? We don't want things that make things grow. Right. So these are some really simple things that you can take a look at. But a lot of people are just trying to use diet to lower the insulin growth factor, but there are other things that it will stimulate it as well.
Yeah, I did notice that. I wanted to go step by step. I don't know if
we're all over.
I did notice in your chapter on hormones, you were talking about how estrogen is a stimulator of cancer, and you're not a big believer in bioidentical hormones. And I even pulled out a quote from where you said that bioidentical hormones are neither safer, more natural than their synthetic ones, which is in stark contrast to most practitioners in the functional medicine community. Can you explain yourself?
I can. Now, believe me, I have a lot of hate mail from colleagues in this arena, and I'm here to say, I'm giving you a couple pictures, because here's the deal. I'm the one who's cleaning up your cancer patients. They might not be cancer patients, they start with you, but they certainly are after they've worked with you. If you've not looked at their SNPs, if you've not looked under the hood, if you've not looked at the way they metabolize their hormones, you are messing with fire. So you bring it. Like I said, data, like people saying be vegan to fight cancer, let me see the data. If you're telling me hormones are safe, let me see the data. It's not, okay? I look at a lot of data. So here's what I mean by this. This is why I'm on my soapbox now, Ben. When people say bioidentical hormones, I've been in huge medical conferences where I've asked the audience, how many of you think that bioidentical hormones are natural hormones? These are doctors. Almost all of them raise their hand. So what gets me is that these are synthetic compounded molecules that are, why they're called bioidentical is they so strongly mimic our own endogenous hormone. That's why they're termed bioidentical. But the caveat is they bind almost irreversibly, or at least more rigidly, to our receptor sites than our endogenous hormones do. So my co-author, Jess, has got some great analogies about, think about the garages, think about your receptors as a garage. When you park an exogenous hormone in there, okay, like estriol, or excuse me, or like estradiol, okay, and like a bioidentical E3, E123 combination. It's like putting a giant Suburban into a place that there's not even room to open the doors. And so it can't let in more information, other things to help pluck it off there and degrade it and move it through the system. And if somebody has SNPs like CYP1B1, CYP2D6, COMT SNPs, ESR2 SNPs, these mean that folks basically take hormones in and they keep them parked in the garage irreversibly. And that starts to kick up things like more 16s, hydroxyestrones, and more 4-hydroxyestrones, which are the toxic estrogen quinones. And if they have certain things like CYP1B1s, they will also take their progesterones and their testosterones and immediately convert them into estrogens, and then park those right inside the Suburban as well. And so that is where, until you really know the way your patient metabolizes their hormones and know their SNPs and know their exposures, like, are they lathering their body with parabens every day? Are they drinking out of plastic? Do they have copper in their pipes? Are they eating pesticide-riddled food? Are they getting glyphosate in all of their diet? They are just adding insult to injury with those exogenous soups they're taking in. So unless you have the money of somebody like Suzanne Summers, who can basically test your labs every few months and adjust accordingly, you really shouldn't be messing with this. And
but what if you are? What if you're, doing urine testing and you're measuring the your estrogen metabolites, and you're making sure that you're metabolizing estrogen in the most efficient way mostly along the 2 pathway.
Yeah. Yeah. If that's the case and you have good SNPs around this, and someone's also looking at your fibrinogen, at your thyroid hormone function, your adrenal hormone function, looking at your circadian rhythm patterns, looking at your liver enzymes, in particular your GGT, and to look at your trifecta and making sure that all that's looking good, then probably you can get away with it. But I'm here to tell you, after reviewing hundreds of thousands of labs and tens of thousands of patients, I've never seen that be the case. And I've never in 28 years needed hormones to bring my patients back to balance exogenously.
What about estriol versus estradiol?
Now, that is the one caveat, is every once in a while, when my patients have not responded to all of my tricks of the trade to bring some good juiciness back to life, so to speak, I might very short term use some estriol topically. So just to give you an example, most people give 2 milligrams and they just have them do it every day, 2 milligrams topically. I have those same patients do 0.5 milligrams for 2 weeks nightly, then twice a week for 2 months nightly, and then once a month for 2 months beyond that. Guess what? It works every time. So less is more in that category. And though I'm testing those folks, I have had a handful of patients where even estriol kicked up their 16s and their 4-hydroxyestrogens because they had such significant SNPs in this department. But it was enough where I've had women who were like tissue paper, taking all vaginal tissue, like that was what it took. And we were able to restore their function safely and effectively. And interesting, as we're changing the rest of the terrain around the imbalances, that little bit of estriol that we brought in for that short term really changed the game, and they never had to go back to it, because it is a terrain-centric process as well.
Now, you're talking about the fact that the estrogen gloms onto the estrogen receptor sites very strongly.
Yeah.
But I noticed in that chapter, you're also not very big on soy. And the argument for consuming soy is that it's a very weak plant estrogen that gloms onto the estrogen receptor sites, thus blocking stronger estrogen. So why isn't that a good thing?
Well, first of all, in the United States, it's a near impossibility to find clean soy. Organic soy does not mean, I will tell you, there has been multiple studies showing that all of our soy, 100% organic or not, is contaminated with glyphosate. Glyphosate does not recognize a fence that says this is organic. It has a 2-mile spread through the air, a 2-mile spread through the soil, and it's in all of our water source. So soy, because of that, it is the nature of glyphosate, it sequesters in soybean crops, all legumes, and all grains. That's its favorite place to hang out. And we're using these foods in the plant-based movement. We're using these foods to, kick up our fight. Like, oh my word, we're actually just gobbling up things that are turning on those insulin growth factors, those estrogen receptors even more. So yeah, you might be getting the benefit of a little bit of support of that soy, but you're getting all the things that are, like, frankly, making it pee in the wind. So there's that. Number 2, one of the things we found, and I have a lot of colleagues out there in integrative oncology who are basically are data-driven research readers who say, the studies really show that it may not be harmful, because there were many years in the camp of saying soy causes cancer. I don't believe that. I just believe
wasn't the largest study ever done with women with a history of breast cancer from China. Those women who consumed the most soy had the least risk of recurrence of breast cancer?
Exactly, and here's why. They have an estrobolome, a microbiome from a cultural background. I was raised in Kansas. Yes, I have soybeans growing all around me, But I did not start eating tofu in Wichita, Kansas at 3 years old, right? That was not happening. So unless you were raised in an environment that's culturally, you were getting through your breast milk, your mother's, tempeh and gorgeous non-glyphosated soybean, that's a whole different ballgame. And so I have just made the blanketed statement in the United States because of the nature of our farming industry. A lot of these are industry-driven responses. We have so many things that work better and are far safer, and I don't even want to question it because I do test and I do see that soybeans, like if my folks are eating a lot of edamame or a lot of tofu, I see that their IGF-1 is high. I see that their estrogens are high. I see their blood sugars are high. I see it. So I'm not making these assertions blindly. And I think it's not necessarily that the soy is the problem. It's what we've done to it and the fact that we're not literally wired in our own microbiome and estrobolome to deal with it.
Cool. Yeah. But you do think flax seeds are beneficial for hormone growth?
Flax seed, right?
Yes.
Not the oil.
Yes.
Thank you. And mostly because it's just like a good binder, a good fiber.
Okay.
And the lignans are pretty anti-inflammatory, but quality is going to be key. You want to make sure it's been vacuum sealed, that you keep it in the fridge, that you grind it as needed.
Right.
Because it oxidizes very quickly. Very quickly. When it oxidizes, that actually kicks up your omega-6s versus what we're going for. Which is in our world today, about 1850, our omega-6 to 3 ratio is about a 3 to 6 to 1 of omega-6 to 3s. Today, it's about a 30 to 1. And that is so much of how we've just sort of monocropped our food sources and put just crappy oil, oxidized oil into everything. And that's also why I'm such an anti-flax oil kind of gal, because it's pretty much oxidized the second you open the bottle, and it just adds more insult to injury.
Yeah, totally agree. So I think I've totally given up the idea of hitting every one of these 10 points. So I'm just going to...
I'm going to do 9 more of these sessions.
I'm just going to grab some points out of your book that I thought were interesting talking topics. In your chapter on genes, you happen to mention that the nutrient choline, which is a vitamin-like essential nutrient, it's an important methyl donor. It's really important for liver health. We had a discussion on the podcast about fatty liver, and choline is one of the most beneficial things for that. We've gone round and round with the TMAO being caused by choline. So we've had a number of discussions on a podcast about choline, but you talk about the fact that some of the data seems to show that men with prostate cancer, that the choline exacerbates their prostate cancer. Can you talk about that?
Sure. And I'm really glad you brought this up, because this actually feeds into a couple other specific nutrients that the data says, hey, this is probably a good fuel source for cancer cells as well. So there is actually a load of literature on choline driving prostate cancer. And choline is going to be richest in eggs, poultry skin. Those are kind of the main ones where we want our, because the data is so strong, I just encourage my men to avoid, with prostate cancer, to avoid those things.
And particularly the egg yolk.
Exactly. So we can kind of get away with some of the albumin, by itself in the egg white, but the egg yolk is definitely the choline rich aspect of it.
Right.
So I'm not, and again, I explain this to people that for the short term, let's see if it makes a dent. I don't have enough long-term data to show, hey, that significantly turned on or off the cancering process, but there is enough data out there to suggest that it's worthwhile pulling it back. Again, that's not forever. And in my mind, it's something that's easy. There's still a lot of other choices, and it doesn't create a lot of stress in the patient. Other things such as glutamine, other things such as methionine, there's discussions about those being drivers of metastatic processes and of cancer fuel sources as well. What I love about all the data around this is why, again, going back to the freebie, intermittent fasting is going to choline restrict, methionine restrict, glutamine restrict, glutamate restrict, glutathione, like it's going to pull all those things that we worry about. And here's my mindset. There was a time when we all just sort of ate whatever was available, whenever it was available seasonally. We were not having access to 3 to 6 meals a day, every day of the year, whatever we wanted, papaya in Colorado in the winter, like those weren't happening. It was definitely seasonal, local, regional, and just what was available. And so we went through many, many moments of fasted states. So we never OD'd on any one particular nutrient, right? I think today, so much of what we're dealing with in the oncology world and the concern is that we're way overfed and undernourished. And we're overfed in ways that keep our sort of balance way tilted. Just like Americans living on soy burgers in the United States, when has that ever happened in our culture, right? And it's like just the same thing, like when have we ever had 6 meals a day, in our history? So that's where even some of my gentlemen are like, oh my God, I ate an egg. And they're all freaked out about having an egg in their keto pancake or what have you. I'm like, well, are you fasting? Are you getting in your 13 hours a day minimum, 16 to 18 hours twice a week, maybe a 3-day a month water fast? You're likely fine. And what the data has shown me over 28 years is that's probably the case.
But you do realize that there's a lot of practitioners out there who are saying, we have to restrict methionine, we have to restrict choline. That means we need a plant-based vegan diet. And I know that you're a big fan of the ketogenic diet. So how do you reconcile those?
Yeah, well, it's easy because it's not, and I'm not really, I got labeled as such as the ketogenic diet because first of all, our publisher wanted us to have that in the title. But I mean, I've been using what I would call a metabolically flexible diet in myself and all my patients for all these years. And so my sister-in-law is a perfect example. Last night, her ketones were off the charts high. And this is a woman who's been trying to do a ketogenic diet for the last 3 years to no avail. She has a very stubborn metabolic process. When she would fast, it would actually make it worse. Her insulin growth factor goes up. And her chemistry, when we started looking at her SNPs and other things, we started understanding that she had some very unique attributes. So what is funny, what will shake my sister into ketosis is a 3-day meat diet or a 3-day protein diet. Nothing but protein for 3 days shifts her chemistry in such that she'll drop physical weight. Her glucose goes way into normal range and her ketones go up. If I did that, I would be the opposite. I go into gluconeogenesis, my insulin growth factor goes up, my insulin goes up, my glucose goes up, and my ketones go down. This is the place that we all need to titrate to our own metabolic, precision individuality process here. So when folks start to say, we have to restrict this, guess what? If you end up on a fruitarian diet or a high plant-based diet with a lot of grains, because plant-based in that realm usually means a lot of grains and legumes as well, you are invariably going to see high insulin. You are invariably going to see high, insulin growth factor, high hemoglobin A1C, high glucose. And you're going to see patterns such as elevated lipopolysaccharides, autoimmune conditions flaring, thyroid whacking out, which is going to change the metabolic burner even more. And so because I'm testing, I can watch. That's why the pendulum drives me crazy, is all these camps interfighting with one another. Look at this person's entire process and see what works best for them and know that it needs to change as they do, whether it's the season, whether it's their condition, whatever. And so that's why, again, a process where we have naturally used intermittent fasting since the beginning of time. Like a lot of people get excited about, the Mediterranean diet. Well, I just spent a month in the Mediterranean and I ate on the Mediterranean diet all but the grains. And the real issue that they're finding, it may be why the benefit of the Mediterranean diet is this is a community of Orthodox Christians who spend 200 days of their calendar year in some form of a fast. That actually may be more of where their medicine is versus the foods they're eating or not eating. That's what I think is really profound. And we can go back. I mean, in ancient times, fasting has been a way of life out of just simple necessity. Just like the beginning of our conversation, I couldn't fit anything in. And so I didn't. And it made a huge difference for me. Just like the gentleman at True Health, True North, he has profound things because sometimes putting in nothing is precisely what the doctor ordered.
Since we're on the topic of prostate cancer, what do you think about modified citrus pectin for prostate cancer? Since I just put up a podcast interview with Dr. Elias.
First of all, I use it every single patient, but I also test. I get a galectin-3 first. Cool. And if it's above 10, then we are definitely using modified citrus pectin. If they have a biopsy coming up, if they have a surgery coming up, I will definitely preempt them with that and keep them on it for at least a couple months post biopsy or surgery. And then our goal is to get the galectin-3 down. And we'll use anywhere from 15 grams to 40 grams a day, depending.
Oh, wow. 40 grams a day.
I've used it in those high situations where I had extreme metastatic, like a galectin-3 of like 35. And we were able to watch every month as it came down and down. Then we were able to maintain it like 5 to 10 grams a day once we hit the sweet spot. It's a very profound support. And what I think it's also doing, and maybe Elias talked about this, I don't know, but is that it also is a great binder, a great fiber. So it's going to be pulling out a lot of the exogenous estrogens, like the hormones, the heavy metals. It's going to be resetting the microbiome. We're getting a lot of pre and probiotics with that pectin as well. So there are a lot of sort of uncelebrated side victories of this supplement that I think are very helpful in a lot of cancer types, not just prostate.
Yeah, he definitely talks about that. And they have some data showing that it binds with lead and other heavy metals.
Yeah.
Yeah.
Cool.
So let's talk about the ketogenic diet a little bit.
Yeah.
So the ketogenic diet is a super, super low carb, very high fat, like 75% fat diet, right?
And that's a therapeutic ketogenic diet, because you can get into ketosis in a multitude of ways. But a therapeutic ketogenic diet is somewhere between 5 and 10% carbohydrate and anywhere from 70 to 90% fat. And then sort of the protein makes up for wherever you are in that equation. And so that is very specific with, as a therapeutic treatment for epilepsy. Okay. What we call kind of like a 4-to-1 ratio of fats to carbohydrates in like the pediatric population. Right. It's also a very important treatment, that particular ratio, and using a therapeutic ketogenic diet is very critical in my personal experience and opinion, and what the literature shows in brain cancer patients. Okay. Those are kind of like the places where you're going to get on a ketogenic diet, a therapeutic ketogenic diet. You're going to stay there for the rest of your long life, is always what I tell patients. And you might be able to moderate your fat intake a little bit over time, but ultimately you're going to need to keep your ketones, your blood ketones, well over 3 to maintain the metabolic need of your brain at that time. Now, for other cancer types, you might need to only be in a nutritional ketogenic state, which is up between 0.8 and 3 on your blood ketones. And hopefully what your listeners are hearing here is the key is, if you're going to implement a ketogenic diet for whatever reason, cancer or longevity or overall health and vitality and fitness, you must test. Most people think they're in a ketogenic diet when they come see me. They're nowhere close. We're so ingrained to think that we're eating low carb. I always tell people that before 1850, we were all low carb naturally. About 30% of our calories came from starches, carbohydrates, tubers, legumes, honey, that we had to work very hard to get, right? After the industrial food revolution kicked in and we started milling sugar and flour, that changed. And now we're all stuck in sugar burning mode, and we are not readily moving into fat burning mode. And today our caloric intake is about 70% to 80% of our calories come from carbohydrates, especially if you are vegan or vegetarian, that's for sure the case. And so that shift that's a big shift, right? And so what's fascinating to me is you can actually create, like I just gave the perfect example of my sister who's eating meat bowls right now for 3 meals a day and got herself into ketosis, where being in true 90% fat intake ketosis didn't work. She has several SNPs that prevents her from using fats to utilize and create the beta hydroxybutyrate ketones. And so for her, it was a whole different ballgame. And we have a lot of patients like that are out there.
And you mentioned blood testing for ketones. Can
Yes.
you talk about the difference? Because a lot of patients are using these urine tests.
Yes. So urine testing is where I start everybody. Okay. So that's where your first morning urine, you're going to pee on a stick. It's like a $6 bottle of urine keto sticks from Amazon. And you're going to use those sticks until you start to see moderate to high ketones on the urine. Once you see that, that's when you graduate to the blood testing. Okay, and there's several devices out there. The cheaper, there's anywhere from probably $50 to $120 for a blood monitor, and anywhere from 99 cents to $5 for a ketone strip. So I always, want people to shop around, because this isn't CME. I think I'm okay can I say the name of the company I like?
Yep.
So I use Keto Mojo because their price point fits and because they're also a blood ketone and blood glucose monitor, and they're very well calibrated and very reliable. So we can even make them reliable to in-office venous draws as well. So that's who I use. And before that, I used Precision for years, but the price point was often prohibitive for most of my patients. So kudos for the Keto Mojo guys for making it more accessible. But what happens when you start to become efficient is you start to become a fat burner. If you are, because anybody can make, like I said, anybody can make ketones, right? But that doesn't mean you're in ketosis. That does not mean that you're metabolically flexible, and that does not mean you're in a fat adapted state. So once you become fat adapted, you should not be showing ketones in your urine anymore.
Right.
This is key. So if we were like, I still show, everyone thinks they're in ketosis, and we're like, you know what? I could go out drinking the night before and show high ketones in my. And so that's what people are doing. And they're out there like, I'm in ketosis. I drank 3 bottles of wine last night. I'm good to go. I'm like, no, you're still showing that you're actually not in a ketogenic adapted state. You're not metabolically flexible. So that's where it changes. What you're seeing in the urine is acetoacetone, or acetoacetate. What you're seeing in the blood is beta hydroxybutyrate, and what you're seeing in breath is acetone. And so like acetone, even a piece of gum can alter it in your breath, or an alcoholic beverage, or just the simple state of not eating for a few hours can kind of blow it off, but it's not a true marker of your metabolic flexibility. Really, the gold standard is and can only be blood. And it's, these little guys are little tiny finger pricks. They really don't hurt. They've got a really good jouster on the Keto Mojo. It's actually quite painless. And it's just the first one's the hardest. It's just that psychological barrier. But once you start to test, you can start to really analyze. And one caveat for your listeners, we're so accustomed to testing our blood sugar, first thing in the morning, or our ketones on the stick first thing in the morning. Your blood ketones, you want to check your glucose first thing in the morning, but you want to actually wait for 3 to 4 hours at the very least to check your blood ketones, because we have something called the dawn effect, which can sometimes make people's ketones erroneously lower for the testing in the morning. So it's like, it's again, not in everybody, but it can happen. And our ketones tend to go up. If we're metabolically flexible, they tend to go up as the day goes on. So I kind of tell people maybe, 11 or noon, or 3 to 4 in the afternoon is a good time to check your blood ketones.
And that's even if you're having breakfast.
Exactly. Okay.
And
that's what's really great is that, if you're eating, you're trying to eat I tell people, don't eat towards the ketone monitor, eat towards your chemistry, and see how the ketone monitor is giving you that feedback. It's like a biofeedback device. That's all. Letting you know how far or close you are to metabolic flexibility, which is the fountain of youth.
That's great. And you've seen real therapeutic benefit in terms of improving the environment in your body, the terrain, in terms of helping the body to fight off cancer with the ketogenic diet.
Got it. Exactly. And here's some really cool data that's coming out and has been for a while, is that being in a fasted state or having elevated ketones at the time of your radiation,
right,
or oxygen or other therapies will actually enhance outcomes. It's almost like the Trojan horse that drives the treatment into the cell and sensitizes the cancer cell to those treatments. Whereas I think it's malpractice that doctors are not checking insulin, hemoglobin A1C, and insulin growth factor on all their patients getting ready to go through radiation, because it's well documented that if you have elevations in those parameters, that you are desensitized to the effect of the radiation, and you make for more aggressive stem cells and more aggressive mutated cancer cells that are already in the system. So it's like, how can we not do this? And luckily I keep meeting at almost every cancer conference I go to now, I keep meeting more and more radio oncologists that are getting hip to this and employing ketogenic diets in their hospitals around the country to put their patients on, at the very least, through radiation, with a recommendation of staying on it for at least 6 months after, because radiation is still doing its thing 6 months to a year after you're completed.
Wow, great.
Right? Yeah.
Cool. I'd like to ask you one more question, and I'm going to have to wrap. Can you explain what cachexia is, and why drinking Ensure and milkshakes with ice cream are not the best answer?
Yeah, another soapbox. And actually, Jess and I, in our next book, we plan to have an entire chapter on this. It's probably the most misunderstood concept in nutrition and metabolic health and cancer care out there. I believe it's the biggest myth to overcome. So the advice often given to our patients is just eat whatever you want, don't lose weight.
So what is cachexia?
Exactly. That's what I was coming to. So
Okay.
what the doctors are worried about is they're worried about weight loss, but there's a difference of like, hey, I'm not eating and I'm losing some weight. And there's cachexia, which is I'm eating everything and I'm still losing weight. Okay. They're different in that they're metabolically based. So when cancer cells take over the mitochondria, take over the system, they basically change the fuel sources and they basically start to starve the muscles of all of their glycogen, like all their glucose stores, and they start to gobble up everything they can of sugar that's coming into the body, that's coming out of the muscles, that's hidden in storage, it's out of the liver, and they start to utilize it to grow tumors and starve the body. That's its job. And the irony of this is it's driven by three main mechanisms. More carbohydrates, so sugar definitely feeds this process. Angiogenesis is a particular process of growing new vasculature to tumors. That also will kick up cachexia, and inflammation. So if you're extremely inflamed and you have lots of blood flow coming to your tumors and not to the rest of your body, and you're eating a high carbohydrate diet, you are absolutely making this process worse. You could eat 20,000 calories a day and you will not stave this off. Okay. And what weight you do gain is going to be the fat and not the good fat. You're just creating little storage tanks for more for more cancer cell proliferating stimulators. So that's a biggie. So things like,
and let me just butt in, for patients who don't know, the cachexia is when you see these cancer patients lose a lot of weight quick, their face gets really thin, and usually that means the end is near.
Exactly. In fact, depending on the studies, anywhere from 50 to 75% of all cancer patients succumb to cachexia, metabolic wasting. If you're in the physical fitness world, you might have heard this as sarcopenia, but basically we see this for a lot of chronic illnesses such as congestive heart failure, cancer, AIDS, HIV. Those are stages where suddenly the metabolic shifts away from nourishing the body to starving the body. That's a very different process, and it's not responsive to calories in. And so the only thing that Boost and Ensure does is it ensures an even more untimely death. Okay. And so that's the key here, is that ironically, even intermittent fasting will help stop this process. Okay. And for sure, a high fat diet, so like a therapeutic ketogenic diet, will stave this off. And even a little bit higher protein, depending on the patient and their needs at the time, especially if they've got a lot of liver mets, they might actually need a little bit more protein, but that becomes a case by case. But it's something that's really misunderstood and mistreated. And it's one of the things that actually your conventional team feels very helpless about, but their way of overcoming it, their way of making themselves feel better is just say, eat whatever you want. And that's not helping anybody, and definitely not helping. So I think the people who need to be educated in this the most are the loved ones of the patient going through this, because as you watch your loved ones start to lose weight, people freak out. Right. And I tell people skinny is not scary. Metabolically, sarcopenic and muscle wasting is scary. And you can see the difference of that on a laboratory assessment. Okay, so if protein levels drop below 7 on your metabolic panel, and if albumin levels drop below 4, you're on the edge of cachexia. And then when it's really bad cachexia, you'll see very low albumin, very low protein, very low calcium, and very low creatinine. So when you see that, you know that the body is already just dissolving its muscle mass as quickly as possible. And then it's even more likely that if you put in a feeding tube or you give them Boost or Ensure, that they're going to die very rapidly.
Awesome. Yeah. This has been a great
interview. Covered some topics. Thank you for that. My goodness.
Tons of great information. I have about 30 more questions. But, so for listeners who want to contact you, where would you like to steer them?
Sure. So definitely go check out my book, The Metabolic Approach to Cancer, that I co-authored with my friend and colleague, there you go, Jess Higgins Kelly. We've got 2 more books coming out in the next year and a half in that arena. And then I also have a co-collaborative book on mistletoe coming out, which will be a whole nother topic. We'll come back together on that. And then they can also go to Dr. Nasha, DrNasha.com. And all my social media handles are in that same realm. And so that is where I try and keep, there's a a ton of other, like your podcast will be on here and all the other media events, as well as events coming up, conferences coming up. It's also a place where we have a really great newsletter where we're bringing you up to speed on the latest research in the arena of integrative cancer, metabolic health, mitochondrial function, longevity, intermittent fasting, ketogenic diet, and a lot of that realm. We just kind of groove out on that. So would look forward to seeing any of your listeners following me there.
Are you accepting new patients?
I'm accepting new doctors to support their
Okay.
And that's where I want, because I was on the one-on-one forever and I did a lot of retreats, which I will be starting back up in 2020. So I think directly, which I'm excited about. But where I find the bottleneck is our healthcare providers. They need to be trained because the patients are savvy. They're finding this information. They know what they're up to. And they're not finding practitioners who can support them on this journey. So my job is to teach the teacher.
So do you have a particular program, or it's a one-on-one type of situation?
Both. Right now I'm doing some one-on-ones, but starting in January, I have a 4-month intensive training for physicians that I've worked with. You can only kind of get into the lineup if you've already done some consulting with me, so you can see if this resonates, because I'm not for everybody, and that's okay. I don't want to be for everybody. I don't have that energy to be for everybody. So, if the book resonates with you, if you have patients that are demanding, you consult with me on their behalf and you resonate with an hour conversation we have, and you realize this cannot just help that person, but hundreds of, or if not thousands of patients in your practice, then I'd look forward to joining you in a deep dive mentoring program that starts in 2020.
Awesome. Thank you, Dr. Winter.
Ooh, what a great time. And I love your podcast. I was able to geek out on it a little bit before our time today, and I'll be following you for sure.
Oh, great. Thank you so much.